So I just wanted to, on behalf of the school social worker, we, like everyone else, were really disappointed. But we also recognize that we're working with a flawed system. The legal aspect of the case kind of made it impossible for a verdict to come back guilty. So we do recognize that. Yet we remain disappointed, just like everyone else, recognizing that there are definitely still some, again, flaws in our system and some injustices. And we know that some of you may have offices downtown. We know that the protests have already started. And so we just want to let you know that you are in our thoughts, that all of our students are in our thoughts. These are always times when our students are upset, and those who are, and all of us are upset, and so it's a time when anger can prevail, but I just want to strongly encourage everyone to not let anger be what sort of spurs you on into action. I want you to move in action, but let that come from a place of love, let it come from a place of truly seeking a change and a desire to see a change. And as you advocate for your clients, as you advocate for yourself, always advocate from a place where anger has not diminished your level of your ability to critically think through situations, and your voice can't be heard if your voice is loud, incoherent. So it helps to organize, and it helps to really be critical as you think about the steps that you take, and I encourage you to encourage your clients to do the same thing. Not to be operating in action, but to allow the action to truly be one that people are going to listen to. And people listen when you're calm, when you're thoughtful, when you're critical. They don't listen when you're angry and screaming and taking that approach. So the anger that you have, I just strongly encourage you to translate that into positive action, so that the only way that a change is going to be made is if we move forward collectively, positively, doing that together, and not, separating ourselves and taking, different approaches that are spurred on by anger. So if you have any questions or concerns or disagree with me, feel free to let me know. I'm around. I'm in and out, and I'm around. So I am happy to talk to you at all, or all of you. So Shalay is going to introduce our next presenter.
Good morning, Shalay Williams-Woodson, and I'm going to just briefly introduce our next speaker, Julie Bertram. She has over 15 years of experience in inpatient psychiatric settings, and she's focused on working with children and adolescents in psychiatric and mental health nursing. She's also trained foster parents on psychotropic medication admin. She is a recent graduate from our doctoral program here at UMSL with a focus area in educational leadership and policy studies, and she is now a full-time tenure track faculty here in the School of Nursing. So allow me to introduce Julie. She brought some very detailed packets, it looks like, so I'm going to pass those out. We're getting some additional ones printed out, and I will pass those out as we get those. Welcome, Julie.
Thanks. Hi, I'm really excited to be here with you, and I recognize some of you maybe just from work in the community. I have done some work in inpatient settings, taking students to various clinical agencies as part of their training. But also I've been working in the child welfare system for the past, I'd say 9 years. And that work began with a consultant role on an NIMH-funded study in which I was hired to do diagnostic and medication reviews. These were youth that were transitioning out of residential care, and they were moving into treatment foster care, and we had a team in place to support them. And my job was to actually review their case files and get information from multiple informants to find out what their history was, but also what were the most useful diagnoses that might still be present, because a lot of times there's lots of diagnoses that get put on over time. And so my job was to kind of really find out what's relevant in this moment for this child that's moving into a different level of care. And then I presented my findings to the family support teams, and I made recommendations. I participated in weekly meetings, and then I developed psychoeducation for foster parents and psychoeducation for the foster youth that were in the study. I loved that work. That actually led to my development of my dissertation research, because we found out that the kids in the study were given multiple diagnoses and were given multiple medications. And so I wanted to find out what was happening there. Why were they on so many medications? What was going on with the decision making? So my dissertation research was looking at the decision making that happens in family support team meetings and court hearings. And then I interviewed stakeholders about their perspectives, and I gave self-rated empowerment scales. My sample was 9 foster youth and their support teams, and then I had 5 counties that were involved in the research. So 2 of the families, there were 2 siblings in the study, so it was actually 7 family support teams, but there were 9 youth in the study. And then all of the adults that were involved in the care were involved, and they had to give consent. That was a very complicated process of getting the child welfare system approval, the university approval, and then making modifications and continuing to ask permission for basically every step I was doing. I did find out so much about how the system worked, and then I actually came away wanting to do more work. And in this next phase of my life, I want to build interventions that help support better care. So since I feel like I've done a lot of homework to find out the context, I feel like I'm well positioned to actually move into some intervention work. So I'm hoping to develop my research line to study outcomes of those interventions. So that's kind of a little bit about me in a nutshell. So I loved creating this title, Minding the Complexity of Psychotropic Medication Utilization Among Vulnerable Children and Youth, because every word in there is a loaded word. So if you're paying attention to medication management for kids in foster care, that is a big deal. And I'm very excited that I get to train somebody in a medical coordination role, and it's sorely needed because children in foster care often have multiple placement changes, and just managing all the nuances of the medications is it's a very complicated process. So I'm going to unpack that a little bit for you, all of the ways that I think it's complicated. And then you might have some questions as we talk, and I think that'll be great for you to jot those down, and we can talk when I'm finished presenting. I created this to be somewhat interactive, so in your packet, on the very first page, I'm giving you a baseline assessment to find out what you know coming in. So I'd like for you, if you've got a packet, and I think you're all going to get one, I would like you to fill that out to the best of your knowledge coming in, and then my hope is by the end of our discussion that you'll have your questions answered. So if you take maybe like 3 to 5 minutes to fill that out, and then we'll move forward in the presentation, and that'll help you get some questions answered of things that you might not have known before. How many people still need a packet? 1, 2, 3, 4? Okay. Okay. You're getting there. Okay, so I'm going to ask you, the very first question on that tool was, what would the targets be for a serotonin-specific medication like Prozac or Celexa? Did you have an idea of what kind of target you would be looking for? Yes, so you're looking at the mood component for an antidepressant, but we also know that serotonin-specific reuptake inhibitors work on anxiety. So some children and youth are actually prescribed those types of medications to manage anxiety symptoms. In that case, we would be looking for an improvement in their perceived level of anxiety. So one of the things that we sometimes don't know from providers is the exact reason why they're prescribing something. But that is part of our job as informed consenters. And if we're in the position of being a guardian, which sometimes people in the social work profession are given some privileges of guardian as kind of dictated by their role if they're in child welfare, then we need to be informed consenters. And that means knowing what the targets of that medication are, what the risks and benefits are, and then what are the other options that are available. So when we give informed consent, we know all of those things. Providers should be giving us that information, but if they aren't, we can certainly ask. And if we're not satisfied with the answers that we're getting or it doesn't seem to make sense, we can question that. We don't necessarily have to get that medication filled or agree to it, and we can get second opinions. So that's part of our job to be advocates, is to be informed consenters. So what was the next question that you had there? Mm-hmm. Oh, okay, so what kinds of things do you need to watch for if you've got a person in your care or custody that's taking lithium? Are you aware of the implications for that medicine? Have you had people on lithium? So you know that it's a salt in the body and that it does compete with sodium in the system, so you really don't want people limiting their salt consumption. You want them to have an even level, neither under nor over abundance of salt in the diet. It's easier to get sunburned on this medication. The blood levels need to be checked periodically during treatment, at least once a week in the initial stages, and then once every 3 months and once every 6 months after the person's stabilized on the medication. So I think in that case, all of the options were yeses, like all of those indicators for monitoring lithium applied. Okay, what about the next one?
A doctor is using medication off-label.
What
What does this mean?
does it mean to use medication off-label? Do you guys know that term? Right. And it's okay for doctors to do that. Doctors are allowed, and nurse practitioners and PAs, to use their clinical reasoning, their experience, and looking in the literature for best practices to make decisions and recommendations about medicines. So it is actually okay that doctors do that, but they should be able to provide a rationale for why they're doing it. So if you have a question about a particular medication, the doctor should have a sound reason behind that and should be looking at target symptoms and should be trying to measure and track outcomes. So if you feel like any of those ingredients are missing, again, you can be in a position of advocacy to question that. How about the next one? You want to go ahead?
A caseworker is attending a medical appointment with a young person for medication adjustment. What are the important things to ask about a new prescription? She's all that.
Okay. So what did you think on that one? All of them? Okay. So just like we said, there's a lot of things that are kind of ingredients of informed consent. So knowing the risks, the benefits, the target symptoms, knowing what to watch for side effects, knowing what kind of monitoring needs to take place, all of those things. Okay, as you went through the rest of that tool, were there any things that you didn't know that you feel like, I wish I knew that, but I didn't know the answer to that? Any questions on those? Okay, let's move forward in the presentation, and hopefully you're gonna come away with not only kind of feeling empowered that you know something more than you did coming in, but also you might leave with some questions, and that's okay. I want to tell you on the very last page, I'm giving you some evidence-based resource places to go get your questions answered. So when we talk about medication management occurs within a larger context, and we want to think of medication use as being one piece of the pie. So psychosocial intervention should be in place. There's an evidence-based clearinghouse for psychosocial interventions, especially for children in foster care and child welfare agencies, and that's provided on the very last page. It's a California evidence-based clearinghouse for child welfare. There's also 2 psychotropic med management guidelines that have come out in 16 and 17. One is from the state of Texas and one is from the state of Florida, and those are readily available online. So if you're ever wondering the dose range or what side effects to monitor for or what other monitoring needs to be in place for a particular medication, those are 2 really good resources that you can go to on the internet. And so that's available to you. So I don't want you to walk away feeling like you don't have any resources. Those are at least 3 evidence-based resources that you can tap into. Okay, so well-being is conceptualized as having the capacities and resources to function. And I don't know if you have read any work by Brian Samuels, but he was in charge of the Children's Bureau and did a lot of publication and advocacy around psychotropic medication management. And he's talked about how it's not enough to just talk about well-being. We need to be monitoring outcomes. And so we need to really have a clear understanding of what we're looking for when we're looking at youth well-being and especially mental functioning. We can look at the last 2 columns, the emotional, behavioral functioning, and social functioning, according to age range. So for infants, infants need to be able to attach to their caregivers, and that's the beginning of brain development. That needs to happen in order for brain development to happen. And then as the child progresses in development, there's going to be some development of social competencies, relationship skills, and then adaptive behavior. So all of those things are kind of developing over time and in the context of relationship. And there's ways that we can track that with assessments, and if we're doing interventions, we want to make sure that we're very specific about what we want to have happen for children and youth that are in our care. We can also look at developmental milestones. Erickson is one that we often use in nursing. So we're looking at what do we want to have happen in terms of developmental progress for a child. So there's different stages of development, and each stage there's a conflict that needs to be overcome in order for a person to move to the next level of development. And when children have been maltreated, there's a developmental insult that happens at that point in time. And that child might need a lot of care and support to be able to even achieve a developmental milestone, or might not ever achieve a developmental milestone because of that insult. So it's good to just see what is it that we're going for. And again, you can look at infants as needing to develop a sense of trust in their caregivers. Early childhood, there's needs for competency and a sense of control in one's environment. And then moving forward, there's skills of being able to take initiative and manage information and problem solve, and then navigate in relationships. And then with adolescence, there's the identity formation. So when we talk about vulnerable youth between the ages of 15 and 24, why is that group particularly vulnerable? They actually are going through rapid developmental growth in the brain where there's pruning taking place. And the impulse control is actually very similar to what we see in toddlerhood. So even though the brain is maturing and growing, the ability to control impulse is actually really low. And so even though it looks like that person is growing and developing and maturing, physically it looks like that person is strong. There's some aspects in which the person really needs a lot of support and sort of like a safety net. So if that person is making mistakes with risk-taking, that someone's available to kind of give them the support that's needed to kind of bounce back. So again, it's important to look at children's developmental milestones. And then I like to look at self-determination theory as kind of a grounding theoretical lens through which I look at children, but also adult behavior. And that theory just says that when people's needs for relatedness, autonomy, and competence are met, then they thrive or have well-being. So that has a lot of implications for the work that we do, that we want to make sure that people have those needs met, or we provide opportunities for them to get those needs met. When we look at specific child and adolescent disorders, we can think of them as being caused by multiple factors. So biological factors, genetic factors, issues with brain development that occur before birth, biochemical alterations, temperament. We can also look at resilience. We used to think that resilience was something that you either had or you didn't, but now we're finding out, of course, that we can help promote resilience with specific interventions. We look at environmental factors, and then we also look at cultural considerations. So this slide just gives you a selected grouping of disorders and what is thought to be the causative reason for a person getting that disorder. And what you'll notice in all of these cases is that there's a genetic component. So sometimes there's not anything that can be done about that, that genetic vulnerability, but then there's also a lot of times an environmental component, and that's something that we can certainly do something about, even if it's promoting the well-being of the mother so that she's giving the baby the best chances for growth and development. But most of these disorders you can think of as a combination of having some genetic or biological vulnerability, and then there have to be environmental factors present as well. So what we can do to promote mental well-being or mental health before someone even gets a diagnosis, start with promoting appropriate prenatal care for the mother, support healthy attachments. That actually begins before the baby is even born. Recognize crises that are associated with loss and provide appropriate opportunities for support and working through losses as they happen. Prevent child abuse and neglect if you have any ability to do that in the work that you're currently involved in. Promote opportunities for a child to develop intellectual interests, and adequate support needs to be provided for children who have limitations. Provide opportunities for creativity, movement, and coping skills. The caregiving actions that we can do, whether we're nurses or social workers or other helping professionals, provision of safety, comfort, health, rest, nutrition, provide assistance with activities of daily living, always encouraging the person to be as independent as possible, provide role modeling for effective communication, set limits to behavior, educate families and children about coping, about preventative health measures, if the person is diagnosed with an illness, about how to manage that illness, teach the people about healthy communication, and then sometimes you might be in a position of administering medication or managing the medication. So if that is one of your roles, we're going to get into some nitty-gritty about that in a couple minutes. There's lots of therapeutic modalities that are available to children and adolescents. So book therapy, dramatic play, movement dance, music, recreation. There's specialized treatment like trauma-informed cognitive behavioral therapy. And again, that evidence-based clearinghouse gives you lots of ideas for if you plug in a specific behavioral issue that you're worried about, you can find the evidence base for treatments according to level 1, level 2, or level 3 evidence. So level 1 would be supported by randomized controlled trials that this is an effective intervention and it's been documented in the literature. Level 2 and 3 don't have as strong of research support, but they might be thought of as promising practices, but maybe not enough intervention or not enough research has been published to support the level 1 grading. So I mentioned right in the beginning that my dissertation research was spurred by my interest in quality of care, specifically around medication use. And so what I found out was, of course, children and adolescents who are in foster care have higher rates of mental health issues and trauma. So there's rates of mental disorders diagnosed at 4 to 5 times the number as children who are not in foster care, and that at least 80%, if not more, have diagnosable PTSD symptoms. So that's one thing we know. We know that children are prescribed more medications, more psychotropic medications than children and youth who are not in care. There's been a lot of concern about that at the federal level. You might know that the states are mandated to put oversight mechanisms in place, and that's highly variable what's happening from state to state. So some states are having a lot of success with their oversight, and they're seeing a reduction in the medication rates, and other states are still struggling with that. Missouri happens to be one of the states that's still struggling with that. So trying to get systems in place, which requires a lot of coordination of efforts. There's multiple systems that need to be communicating with one another, and it's not necessarily happening as easily or as well as it could be. And my dream would be that these databases would be merged, so the court system, the medical files, the child welfare files, the education files, that all of those databases would be integrated, but it is not the case right now. So it's very difficult for workers to get a handle on what's going on. And so we're struggling. The state of Missouri is struggling right now. So do we have a shared understanding of what the problem is? Okay, and what do we need, do you think? Besides what I just told you, the data integration, what else do we need? Yeah, better communication, better information sharing. It may be not happening as well or as often as it should be happening. Any other gaps that you see that you're aware of?
I was just education, I mean, just in general on medications and side effects.
Yeah, so that's not necessarily something that you're necessarily trained in all on your own. You might not have had any pharmacy classes. You might not have had any classes on laboratory monitoring, the anatomy and physiology of the body, all of that kind of stuff. So I think there's a need for the helping professionals to have an increased level of knowledge. And like I said, maybe you don't take all those classes, but to be able to know where to go to find your answers. So it occurs to me, how do I, as a nurse who's had advanced training, how did I get to the point where I know where to go look? It was a process of development that occurred over many years that I'm able to now go and access the databases that I need to find answers to my questions. But that's not necessarily something that I can assume that all people have access to. So I want to reach out to people who don't have that information and give them the resources that they need so they can go answer their own questions. So yes, I agree that not having the knowledge base is a gap. And so I will want to share with you what I know so that hopefully I can fill in some of those gaps for you. So if I introduce the trauma lens, I'm looking at children and youth who are in foster care as people who are surviving traumatic experiences. And SAMHSA gives us a good definition of what trauma is. It's an event or series of events or set of circumstances that is experienced by the individual as physically or emotionally threatening or harmful, could potentially even be life-threatening. And it affects the person's functioning in multiple areas of living. And so it's really leaving a lasting impression. And it affects the way the brain and the body works. And we also want to keep in mind that systems that are designed to help could potentially actually be perpetuating traumatic experiences. So we want to be mindful of that. And so the trauma lens is a way of looking at and interpreting and responding to an individual's circumstances, as well as the family and the community's experiences, that actually validates people's experiences and hopefully seeks to reduce or eliminate harmful practices. So that's looking at the trauma kind of context and how we could approach the care that we give. The other thing about trauma is it doesn't necessarily have to equate to the person having PTSD or a diagnosable mental disorder. And if you look in trauma recovery literature and trauma-informed care, a lot of people who have lived through traumatic events or circumstances really don't view themselves as having a disease process. And it might be helpful if we look at people as not having a disease either, that they have explainable and understandable responses to traumatic events in their life, and that doesn't mean that they're sick. So these are the medical words that we could use if we look at patterns of behavior and say the person has a diagnosable condition. But I would kind of challenge us to think that maybe these aren't disease processes. Maybe these are just understandable responses. But in the DSM, we've got lots of categories of diagnoses in a whole chapter on trauma-related disorder. So again, it's kind of pathologicalizing human responses or saying that these are sicknesses. And that's one way of looking at it. And you might start to construct a different understanding of that. The more you get trauma-informed, you might have a different understanding of what people's experiences are. But we've got the PTSD diagnosis, acute stress disorder. We've got the reactive attachment disorder label. What do you think the bad thing is about these diagnostic labels and categories? What do you think's bad about that? Well, what's good about it? Huh? It helps you get paid for the services that you provide, so you can bill for it, right? So you can communicate with the insurance company and say, I'm doing this service for this individual because they have this condition, I'm doing these interventions, and it costs me some time and resources, and I'd like to be paid for my services. So that's one good thing about it, right? What else is good about it? Yeah.
Symptoms, they don't know why it's happening, and then when a name is given, they experience some relief. Like
right.
They don't feel as crazy.
Right. So for some people, it provides a sense of, oh, there's a name for what I have. And that makes me feel better knowing I'm really not crazy. There's actually a word for what's going on with me, or there's a description of this phenomenon that I have. So for some patients, it provides a sense of relief to be able to communicate in a common language about what's happening. For providers like social workers and counselors and psychologists and psychiatrists and nurses, it gives us a common language for talking about what we see in our practices. So that can be another potential benefit, is it gives us a common language. The thing that I would say is the bad part is the stigma. There can be self-stigma and there can be public stigma. So the self-stigma might prevent people from getting the help that they need because there's shame and the person feels as if I need to keep this to myself, I shouldn't tell anybody. And there can be stigma from outsiders who look at that person and view that person through a biased perspective. Expectations about how the person will function or behave, and may project expectations about how well this person will do with any kind of treatment or services that are offered. So that's kind of the downside of the diagnosing. I gave you the PTSD criteria, which you've probably seen lots of times, so that's kind of probably a review for most of you, and so I'm going to skip forward on those criteria, but just if you want to go back and review the criteria for PTSD, you can do that. In nursing, we kind of have a holistic way of kind of labeling the human responses that kind of goes beyond the diagnosis to what is it the thing that we're going to try to address. So when we look at people that have post-traumatic stress disorder, we might be concerned about this person harming him or herself or directing harmful intentions to other people. So if we set up outcome criteria, what do we want to have happen with our interventions? We probably want to evaluate for signs and symptoms of those impulses, provide safety, encourage identification of triggers, so those things that activate a person's fight or flight or freeze response, and teach that person how to manage those triggers for him or herself so that they can lower their likelihood of having maybe just some dysfunctional patterns of behavior. So we want to teach people to recognize triggers and then to try to self-soothe and modify circumstances so that those symptoms don't flare up. We can teach people about grounding. We can also do de-escalation techniques. We also look at people's anxiety, and what we can do as healthcare workers to lower anxiety. First of all, it's assessing where is this person at? Is it mild, moderate, severe, or is this person going into panic? And then I think what's shared among many helping professionals is we want to help develop a trusting, supportive relationship because we know that that's going to decrease anxiety in the person who's experiencing it. We want to determine what kind of effects this anxiety is having on the person's mood and affect, and then create situations where there's less stimulation and create more situations in which there's a calm environment. If we know that the person has problems with coping, we're going to teach coping skills. Medication management and coping are kind of interesting because medication is one way to manage symptoms, but it doesn't really address how the person is managing and responding with their own resources. So medication might reduce symptoms, and that's useful, that's helpful, but it's not the only thing. So when we talk about targets for psychotropic medication, what are we looking for? What do we want to have happen? What do you think? People are having symptoms. What kinds of things do we want to take care of?
We want an improvement in the symptoms to have fewer.
Yes, and what kinds of things do you think medication can help with? It can help with mood. It can help with sleep disturbances. It can help with anxiety, that's right. And by doing these things, we make it more likely that the person will respond to the other interventions that we're offering. So target symptoms that we're looking to modify could include sleep pattern disturbances, mood disturbances, disturbances in the level of anxiety or worry, and even appetite changes. That would be another target. If that's a symptom that's bothering the person, that's something that we can do. So we use medication to relieve symptoms. This will in turn help the person function more effectively, may help the person receive our other interventions, but should not be used as a standalone. So Sharon earlier was talking about how we notice that we might be angry, but we don't want to operate out of a place of anger because people aren't going to listen to us. So people with mental health concerns, a lot of times, their emotions are so heightened and they're feeling so disorganized and upset that they're not able to problem solve. So we want to get those symptoms under a level of control that the person is going to be able to think through in a clear and focused way, an approach to managing those situations that are difficult. So that's what the medicine is for. In terms of FDA approval for trauma symptoms, there are no FDA-approved medications for PTSD in children and adolescents, but the SSRIs have been used for adult patients with some success, and we do have randomized control trials that show us that they're effective with adult patients. So we can generalize that, and some providers are using the SSRIs with children when they have very severe symptoms, and the other therapies are maybe being tried, and that can be as an add-on to the other therapy that's being offered. If the medication is used, the target symptoms need to be monitored. So whether that's sleep disturbances or whether that's excessive anxiety or appetite issues, those target symptoms need to be monitored to see if they're getting better. Out of these safety issues related to medication use, which ones are the most worrisome to you? Is it the side effects with black box warnings that you see on these prescriptions? Is it the combination of medications? Is it issues of adherence or whether the person's taking it? Comorbid conditions or substance use? Which of those is most worrisome to you? They're all pretty worrisome. It depends on the context. For me, as a nurse, I think the black box warning gives me a lot of concern. That just means that the medication use is risky, and we have to keep a close eye on the person and make sure they're not becoming suicidal or manic. That concerns me a lot. And the other one for me is the medication combinations, because there can be drug interactions that could potentially be poisonous to the body. And so as a nurse, that concerns me a lot. But I like your answer that it depends on the context, it depends on the person, what your concerns might be for that individual. What you can begin to do right away, of course, understand that children can react to trauma in different ways, and that doesn't necessarily mean that person has a diagnosable condition. The child's reactions can be understood through the lens of trauma. You can refer to trauma-appropriate services. If you're concerned that a child is being overly or unnecessarily medicated, advocate for a second opinion. And then assure that those medications are being used as a part of a comprehensive treatment plan. That's really important. These are some target symptoms of medications used in child and adolescent psychiatry. And what we kind of see from this chart is you can have anger and depression in lots of different disorders. You can have impulsive behaviors for many conditions, destructive and defiant behavior. So even though kind of a guiding rule for providers is you should first get a good assessment, then you should have a clear diagnosis, then you choose the medications in the treatment plan according to the diagnosis. It's not so easy to do that with children and adolescents because they're still growing and developing and there's a lot of overlap in symptoms. Yeah.
I just had a question about medications and stuff. So, years ago, I'm pretty sure it used to be that, like, for a child, and I don't know up to what age, if you gave them a stimulant, it would react as a depressant, and if you gave them a depressant, it would react as a stimulant. Like back when they would give children
Ritalin?
Ritalin.
Okay.
Is that the same thing?
Okay, so we're going to talk about ADHD and the medication use and the reason the medication works and what's going on with the physiology in the brain. So I have a few select conditions that we're going to go through. So they're autism, ADHD, depressive disorders, bipolar, and psychosis. So autism disorders, I think you are aware that that's becoming increasingly common, like 1 in 68 children are diagnosed. Once children are given medications for their autism spectrum symptoms, it's a lot harder to get off the medication. There is some brain pathology going on with that disorder in which there's an overabundance of synapses. So the brain is actually, instead of pruning back the synapses that aren't needed, that's not happening. So that's kind of the pathology of that disorder, and there's a strong genetic component. Because I want to get to your question, I'm going to kind of skip ahead with all of the pathophysiology of autism to get to the medications. So when you do medication management with autism spectrum disorders, there's 2 FDA-approved medications. There's risperidone and Abilify. Those are used to treat the targets of obsessiveness and aggression, self-harming behaviors, and temper tantrums. they're not going to cure the disease process. They're just going to make it easier to manage those behavior manifestations. And you probably know the other approach is applied behavior analysis, and that there's usually a multidisciplinary approach when a person has autism spectrum disorders. The one thing I want you to be aware of is once you start medication with people that have that autism spectrum disorder, it's really difficult to get off the medication. It's not that you shouldn't ever use medication, but just to be aware of that. And those medications can cause the type 2 diabetes and the metabolic syndrome. So they're not without their risks. This is like a care planning chart that gives you the human responses to autism and what you could do besides medications to help address those. And then I told you the FDA approved uses. So I'm gonna skip to ADHD because that's what you had a question about. So ADHD is diagnosed by 3 symptom clusters: inattention, hyperactivity, and impulsivity. Those are the symptom clusters. In order to get a good diagnosis, the child should be observed in multiple contexts, and there should be multiple informants that are giving information to support the validity of that diagnosis. One thing we know is that children that have been traumatized often present with impulsivity and inattention and may not truly have ADHD. If you give stimulant medication to someone who has hyperarousal, which means their fight or flight system is always on, that they're very reactive and responsive and hypervigilant and easily startled. If you give stimulant medications to someone like that, what do you think will happen? Stimulant increases the heart rate, it increases the norepinephrine. It's actually probably going to make things a little bit worse for somebody. So that's why we need to have that trauma-informed lens when we're looking at behaviors, so that we make sure that we're providing as much relevant information to the provider as that provider needs to make a good diagnosis and treatment plan. So the reason that sometimes symptoms get worse is because maybe the diagnosis isn't correct and the medications that are going to be given for that particular diagnosis aren't actually helping. They actually might be making symptoms worse. So stimulant drugs in the brains of people that have ADHD work a little bit differently. So I'm going to skip ahead. I put all of these behavioral interventions just because I want you to see that bigger context. But so what we think happens in the brains of people that have ADHD is the prefrontal cortex, that part of the brain that makes us most human, that allows us to think through, organize, plan, or what we term executive functioning kinds of things that our brains do. That part of the brain doesn't seem to be working as well. The stimulant drugs actually make that prefrontal cortex work more effectively, and so that person is able to then focus, concentrate, maybe sit still if they're kind of squirmy and hyperactive, and control impulses better. That's if the person really has ADHD and the prefrontal cortex is the problem, then the medication should work in that way. So the stimulant medications, if given in the right circumstances with the right brain pathophysiology, should work to reduce symptoms. So if you have the wrong diagnosis and you put ADHD medication on that, you might not necessarily get the same result. So you could have, sometimes I can remember I did a Rainbows support group for children, and one of the girls in the group, she seemed like she was depressed. She was in the group because she was a child of divorce, and that was what the group was for. And I remember the school counselor telling me, I want you to know something about this little girl. She looks like she's sad, but actually she does really well in school. She's able to focus and concentrate. And she has ADHD, but it's the inattentive type. She really didn't have the hyperactivity, but she had difficulty with focusing and concentrating. When they gave her the medication, she was really able to do much better in school. So that medication was working for her, but it kind of dulled her emotional expression. She didn't look like really overly cheerful or happy. So you might see some of that kind of presentation if someone's being given medication their emotional expression might look a little bit different than they did maybe if they weren't on medication. There's lots of different stimulant drugs that are available, but those aren't for everybody. There's some children who have heart conditions, and those stimulant drugs could be risky for them. And then some people don't respond to the medication. So between 70 and 90% of children with ADHD that are prescribed psychostimulant drugs do respond, but there are some people that can't tolerate the side effects, or they have other comorbid health conditions in which it wouldn't be a good idea for them to take that medication. So some alternatives would be clonidine and guanfacine. Those are both alpha-2 antagonist drugs. They actually, the net result in the brain is the same. It's going to make the prefrontal cortex work better. It'll help reduce aggression, reduce anxiety, kind of calm that person down to be able to think in a more planned out and organized way. They do occasionally use tricyclic antidepressants, bupropion and Strattera. Do you remember anything in particular about Strattera? Does this sound like something that you don't see very much use of? Well, we're using it with children. It works on the norepinephrine, but after they had the FDA approval and that more people were using it, some children were developing liver toxicity and liver failure, so I think psychiatrists are a little leery of using that medication because of the adverse events that happened after the FDA approval was, allowed that drug to be marketed. So I don't see that drug being used a lot, but that is an alternative to a stimulant drug. You just have to be careful with monitoring. So what are you monitoring for? For a child that has ADHD, you're looking at mental status, you're looking at, see that if that person's able to function better in school and relationships, and even at home, learning is happening all the time with play and with interacting. So you're looking at behaviors, not just in school, but also in the home environment. You're looking at the level of anxiety. If that person's aggressive, you're looking to see if that person's aggression is lessening. And if there's some injuries that have been happening because of impulsivity, hopefully that medication is reducing the impulsivity and there's going to be less injuries happening. This medication can cause some adverse side effects. One is a loss of appetite and reduced growth and development, so that needs to be monitored. And you might rearrange the eating schedule for someone who's on a stimulant drug, so you're maximizing the effect of the medication, but also the times when the person will be most likely to have an appetite. So it might be the person has almost like a dinner meal before taking the morning med, and then may just have small snacks throughout the day, and then at the end of the day might have a bigger meal. So you don't necessarily have to do the same meal plan for a person who's on a stimulant drug as you would for the rest of the family, because the appetite is going to be altered as a result of the stimulant. And that's okay. You don't have to do everybody the same in the family. You want to administer the medication at least 6 hours before bedtime to reduce the possibility of insomnia. And if it's a sustained release form, it should be administered in the morning. The young person should be weighed regularly just to kind of keep up with kind of tracking what's going on here. Is this person making weight appropriate to height and what's expected developmentally, or is the person off the growth chart in some way? And that just needs to be monitored. Somebody needs to be tracking that. You also want to look at what other medications are being prescribed, and if you're teaching families, cold products sometimes contain stimulants in them that could be harmful for people that are already prescribed a stimulant drug. So just educating families about the potential drug interactions would be important. Okay, I'm going to move on. There's only a couple more drug categories that we're going to go, and it's kind of put into this bigger context of like the diagnosis and all the interventions, but I'm gonna try to just zero in on the medication aspect because I know that's what you are most interested in. So we'll talk about depression, bipolar, and I think there might be one more on the end of that, but I can't remember which one it is. So for depressive disorders, you know that there's a variety of medications that can be used. And so I'm gonna, of course there's other treatments besides medicines, but SSRI, serotonin-specific reuptake inhibitors, and serotonin norepinephrine reuptake inhibitors, those are the two like gold standards for children and adolescent medications. The other ones like atypicals, MAOIs, and tricyclics, those are rarely used, but you might see them occasionally. The reason the MAOIs and tricyclics are rarely used is because they have side effects. The MAOIs, you have to follow a special diet. The tricyclics can cause cardiovascular side effects, so that's the reason for that. These medications work by blocking the reuptake of serotonin and or norepinephrine, and sometimes also affect dopamine. So like Wellbutrin is an atypical, and it works on dopamine receptors. Usually it takes up to 8 weeks to notice any improvement from the medication, but a lot of times people notice the side effects right away, and it's hard for them to kind of overlook that, but I think you could just validate the person's experience and tell them that's not unusual, but a lot of times these side effects kind of diminish over time, and pretty soon you're going to start to notice the benefit of the medication. You should monitor for improvement in symptoms, have regular follow-ups, and monitor for side effects. I've listed the side effects on the left side, and I just wanted you to be aware of that black box warning, which is that young people in particular are vulnerable to suicidality. It might be part of their depressive disorder, and when you introduce an antidepressant, they have done some research to show that the introduction of the medication corresponds with an increase in suicidality for some people. So you just have to be aware of that. Doesn't mean that you shouldn't use the medication. In fact, we want people to be treated. If that's the appropriate course of action, we want people to get the help that they need, but you just have to be aware of it. It's a possibility. For bipolar disorder, you know that's a combination of depressive and manic symptoms, and I want to skip to the treatments. So antipsychotics is one way that you could treat bipolar disorder. So at the top, I have the drug category, antipsychotic, and I broke it up into two subcategories. So conventionals, those were the older antipsychotics that were first developed like in the 1950s and 60s. Examples would be like Haldol, Thorazine, Navaine, Orap. They're older drugs. You might occasionally still see prescribers using them. They're usually not the first choice, but maybe someone whose symptoms are difficult to treat and that person hasn't responded to other medications. The mechanism of action of that group of drugs is to block dopamine. It can cause side effects. Those are called extrapyramidal side effects, and there's different subtypes of those extrapyramidal side effects. So the extrapyramidal side effects are because the dopamine is being blocked in the brain, and that causes a corresponding drop in the acetylcholine function. And that, in turn, causes some movement disorder. So you can have akathisia, which is the motor restlessness, pseudoparkinsonism, which it looks like the person has Parkinson's disease. They might be shuffling their feet, walking with like a stooped posture, have like a wide mask-like facial expression, and have a slowness of changing positions. Those are all associated with dopamine blockade, and the reason they call them Parkinsonian side effects is because you see those same symptoms in people that have Parkinson's disease. And if you look at the pathophysiology of Parkinson's disease, it's the same as what happens when you block dopamine with these drugs. There's a reduction in dopamine that causes, the net effect is it's also changing the neurotransmission of acetylcholine, and that's responsible for the movement disorder, okay? So you need to kind of recognize if those side effects are occurring and then make sure that you report it. Those side effects can be treated with cogentin, which is an anticholinergic. That'll restore the balance of dopamine and acetylcholine, and it'll hopefully take care of those side effects. The other one that doesn't respond to medications is called tardive dyskinesia. It's another side effect. And that's like involuntary movements of the face and sometimes the trunk. It's very highly stigmatizing for the person because the person will have these unusual expressions and the person can't control it. There's not necessarily medication that can fix that. So that's probably a reason why those drugs aren't used as often, because they can cause that tardive dyskinesia. Not necessarily reversible even if you stop the drug. And then atypical antipsychotics, we used to think those were really superior, but we've now found out that they cause metabolic side effects and type 2 diabetes, and they can still cause EPS, and they can cause agranulocytosis. So it turns out they're really not so great as we thought they were. But I think it's just important to know that, you know, those are available. They work a little bit differently. So they work on serotonin and dopamine. So if you have a person that has bipolar disorder, what they're finding out is that there's a common genetic mechanism with bipolar and schizophrenia, and that's why these antipsychotic drugs are working on people that have bipolar, because typically you would think, well, aren't antipsychotics supposed to be used for schizophrenia? But actually, when you look at the genetic ingredients of those disorders, there is some overlap in what's going on at the level of genetics, and that might be why the medication can be used in both conditions. So just to know, antipsychotics doesn't mean the person has schizophrenia, can be used for bipolar disorders. Then you've got mood stabilizers, lithium, and anticonvulsants. Lithium we talked about right in the beginning when I gave you that test, and then the anticonvulsants, those are drugs that they found out by accident that those help people with bipolar disorder. So typically you think of anticonvulsants being used for people with seizures, but they found out they also work with people that have bipolar. So I've given you the drug name, the examples, the mechanism of action. Most drugs have possible side effects, and I think it's important to kind of be able to pull out what are the most important things that I need to pay attention for? Because usually when you get a prescription filled, they're probably going to give you like 30 different side effects, and it's hard to know, well, what's most important? You always want to think of suicide risk, potential activation of mania, and any physiological changes with rashes or liver functions, heart functions. Those are the things that would be like your priority concerns when you're looking at these types of medications. So yes, you're going to get this huge long list of side effects, and it seems overwhelming, and you don't even know what to pay attention for. But I would just like think of a handful of things that you really want to be concerned about. And again, it's the suicidality, mania, changes in the liver function, changes in the heart function. Those things are pretty important, and if the person would have an allergic reaction, you need to pay attention for that. Schizophrenia, pretty rare in children and adolescents, but it can happen. Usually there's a prodrome, which means there's a period of time before the illness becomes manifest that you're going to start noticing some unusual behaviors, but it's actually pretty rare to see children diagnosed with schizophrenia before the age of 12. Late teens, early 20s, prime age for people to get this diagnosis. So if you're working with that age group, just be aware that when you're noticing something's a little bit off, if the person seems to be increasingly preoccupied and withdrawn, it seems to be increasingly paranoid, these are some warning signs that the person might be on the edge of going into psychosis. So you just need to pay attention for that. I put the clustering and overlapping of symptoms, which is probably too much for you right now, because we don't have enough time. I gave you way too much. I do want you to know long-acting injectables are a type of a treatment for schizophrenia that we shouldn't just keep as a last resort. The good things about the long-acting injectables are you get a steady amount of the medication over time. It improves the person's ability to receive interventions. It improves the engagement with the provider. And so that's something that I want you to open your mind up to the possibility that it's not always something that should be used as a last resort. Okay. Let's just summarize. In review, why do we use these medications? Relieve symptoms. It helps the person function more effectively. helps people receive services, should not be used as standalone. And then your last thing is, what can you do right now? I think one of my takeaway messages, you want to understand the context of trauma, obviously, and assure that medications are used as part of a comprehensive treatment plan. I know I went a little bit over, and thank you so much for your patience. I gave you way more than you could possibly absorb in an hour, but my hope is that you got curious and you want to go looking for more answers and more information, and that you want to continue the conversation, either with me or with your colleagues, but that you're not done learning about it, that you're just kind of spurred to learn more. Any questions that you have?
Can you make your PowerPoint available?
Yes, I can. They're way too tiny for you to read. Oh, I put in your packet also the foster care guidelines from Texas. So that's in your packet, and I just printed the whole thing out for you. So if you're a person who works with children in foster care, or just you feel like they're highly vulnerable and you're not really sure, you know, is this dose right, or what should I be looking for? The Texas guidelines are in there for you. And I will share this with Sharon. And then does she have y'all's email? Did she collect that? So she can send the slides out to you. Okay, good. Thank you so much. Any other questions? Okay, thanks.
Actually, that's what I was going to say, is that our printer kind of went berserk, so we couldn't print out copies for this half of the room, but Julie's going to make that available, and we will definitely email that to you. And I'm hoping will be available during lunch.
Yes, I will.
The food truck is here if you are interested in getting lunch through that. There are other places available on campus. I think Diane perhaps going to share.
I just wanted to tell you that we have a little menu for the food truck right on the table out there, so you can grab one